Let me introduce our esteemed speaker, Dr. Vijay Bhargav, who is a renowned medical oncologist and HOD at Jawaharlal Nehru Cancer Hospital, Bhopal. Dr. Bhargav has completed his education from GCRI Gujarat Cancer Institute of Gujarat, Ahmedabad, and has an extensive experience in managing wide spectrum of cancers across the country, sir. So today, Dr. Bhargav will be sharing the valuable perspective on the darolutamide, sir. So requesting all, please join me in welcoming Dr. Bhargav, sir. Over to you, sir.
Thank you, Deepak, for giving me opportunity. Thank you, Bear, for giving me opportunity to be discuss the new data on androgen deprivation with apalutamide only. So we will proceed. Can you run slide for me? Deepak, should I go for the slide or any one of you can run slide for me? Oh, thanks. So by today evening, we will discuss darolutamide in hormone-sensitive prostate cancer. So darolutamide in ARANOTE, a new benchmark in metastatic hormone-sensitive prostatic cancer therapy. Next, please. So this is the disclosure as the peer-sponsored session. So the standard of care in metastatic hormone cancer. So here we can see the charter trial established the docetaxel with androgen deprivation as the standard of care in 2014. Then in STAMPEDE, docetaxel with and (2015). Then Latitude trial with hormone therapy. STAMPEDE arm is showing abiraterone with androgen deprivation in ARC study, and Titan apalutamide androgen deprivation. Here apalutamide comes in picture in 2019. Then further trial established the darolutamide with androgen deprivation with docetaxel in ARASENE in 2022. And then 2024, ARANOTE is androgen deprivation with darolutamide alone. And ARASEC is darolutamide with androgen deprivation alone. So this is the new standard of care avoiding the chemotherapy in metastatic hormone-sensitive prostate cancer with androgen deprivation therapy with androgen receptor blocker. Next, please. So there is unmet therapeutic need and unmet medical need remain for an efficacious treatment that offer a differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and with a low drug-drug interaction potential. In ARASENE phase 3 study is a combination of docetaxel already shown many medical efficacy, beneficial efficacy and safety profile in metastatic hormone-sensitive prostate cancer patient leading to its approval in 2023. Darolutamide in combination with androgen deprivation would provide efficacy benefit with a favorable safety profile in metastatic hormone-sensitive prostate cancer patient as demonstrated in the global phase 3 study ARANOTE trial with significant Indian patients. With the ARANOTE data, darolutamide has the potential to change the treatment paradigm as now it would be the only ARI which could be used with and without chemotherapy. Next, please. So darolutamide with androgen deprivation, docetaxel is a standard of care both metastatic hormone-sensitive prostate cancer. In ARASENE, darolutamide with androgen deprivation with docetaxel demonstrate favorable efficacy and safety versus androgen deprivation with docetaxel alone in patient with metastatic hormone-sensitive prostate cancer. Aranot was designed to evaluate darolutamide with androgen deprivation therapy versus androgen deprivation therapy to provide a new treatment option for metastatic hormone-sensitive prostate cancer without docetaxel. Next, please. So Aranot study design, here we can see the randomized double-blind placebo-controlled phase 3 study with metastatic hormone-sensitive prostate cancer, histologically or cytologically confirmed adenocarcinoma of the prostate, ECOG performance 0 to 2. Stratification factor is the visceral mets assessed by central review. Prior local therapy, yes or no. Darolutamide in control arm, placebo with androgen deprivation, 2:1 randomization with patient arm, that is the darolutamide, 600 milligram BD with androgen deprivation. Primary endpoint is the PFS. Secondary endpoint is the OS, time to initiation of subsequent antineoplastic therapy, time to castration-resistant prostate cancer, time to PSA progression, rate of undetectable PSA, time to pain progression, and safety. Other specific endpoint at PFS2, time to associated SSE events, time to deterioration of FACT total, and time to first prostate cancer related invasive procedure. So the open label darolutamide with 100% crossover to open label darolutamide and selected endpoint in OS and safety. So median follow-up for darolutamide group is 25.3 months and placebo control group is 25 months. Next, please. So the demography here is the clinical characteristic at baseline. All the race age group is median age 70 in both arms. That is the comparable. All races including white, Asian, black, and other are included in both arms. Asian, Latin American, or European region is also conducting the trial. ECOG performance with good performance, 0 ECOG, 2 poor PS, 1 to 2 is all included in comparable number. Gleason score 4, 8 or more in the 21% of patient in both group. And metastasis, de novo mets or no metastasis with recurrent disease is all comparable in the both groups, including the disease volume, visceral mets, and prior local therapy is comparable in the both group. Next, please. So here the distribution of the country representing the across baseline, and we can see the prostate cancer patient are comparable in the whole world. Aranot trial is showing the study population including the whole world. Embark is also controlling almost all the America, South and North America, European countries and Australia, but devoid of Asia, especially and Africa. In Vision trial also the North America and Europe is the patient recruitment site. And here we can see the COMA trial is also confined to Europe, Northern America and Australia. So the Aranot is significantly controlling all the continent for the patient recruitment. Next, please. Here the Aranot, we can see the Asia Pacific region also including all the country including China, India, Taiwan, Australia, New Zealand also. Next, please. So darolutamide with androgen deprivation significantly reduce the risk of radiographic progression or death by 46% versus placebo to androgen deprivation therapy. So hazard ratio of PFS is 0.254% with p-value of 0.0001. Darolutamide with androgen deprivation have median darolutamide group is saying median follow-up to 70 months as compared to 52% patient survive for the placebo and androgen deprivation arm for almost 2 years. So after 24 months of follow-up, we can see that 20% difference in the survival rate in the control group as compared to drug group. Next, please. So the benefit of darolutamide with androgen deprivation on PFS was consistent across subgroup and including patient with high and low volume disease. So all the patient with high and low volume disease with benefited from the therapy arm as compared to placebo arm. Next, please. So darolutamide with endogen deprivation demonstrated a benefit across all the secondary endpoint, like overall survival, time to metastatic CRPC, time to PSA progression, initiation of subsequent systemic therapy, and time to pain progression. So all the parameters are included and benefited with the control arm treatment arm as compared to placebo arm. At the time of primary analysis, OS data was immature. Since OS is immature, patient will be followed for survival, and all remaining per protocol placebo offered across over to darolutamide after the primary analysis. Next, please. So time to metastatic CRPC, we can see the darolutamide with endogen deprivation has median follow-up of 95% confidence interval. For the 3-year of follow-up, we can see almost 70% of patients survive as compared to 20-30% patients survival in the control arm. There is a delay in the pain progression also. The darolutamide patient are 70 to 80% patient are pain-free after the 3-year, which are the reduced to 40 to 50% patient in the control arm. So delay in the time to pain progression can be high importance of patient who have not been demonstrated with the other AR inhibitor to date. Next, please. PSA 0.2 nanogram per ml means undetectable PSA during treatment is also high in the darolutamide, that is 62.6% as compared to 18% only in the control arm. And time to progression of PSA is also high after the almost 39 of month. 80% patient doesn't have a PSA progression as compared to placebo. Only 30% patient are PSA stable in the control arm. Next, please. So here the pie diagram showing high proportional of the patient achieved undetectable PSA with darolutamide versus placebo in both high volume and low volume subgroup. Next, please. So subsequent life prolonging anti-cancer therapy, patient with subsequent life prolonging systemic therapy, 66 out of 203 and 68 out of 160 patient. So we can see the 10% difference. There is significant difference in the progression in patient and life prolongation in the patient on darolutamide as compared to placebo. Next, please. So the incidence of therapy-related adverse events were similar between the treatment corpus and discontinuation were lower in the darolutamide arm as compared to control arm. And here we can see that the adverse event is almost comparable in the both subgroup with significant improvement in the survival and pain-free symptom in the darolutamide. So median treatment duration was 24 months in the darolutamide versus 17 months in the placebo arm. The safety profile is RA0 was independent of PSA and favorable tolerability seen in RMS versus Aracina. Next, please. So chemo-free arm is definitely having better tolerance as compared to chemo arm. Next, please. So the rate of most common adverse event were low and similar between the treatment arm, and here we can see the fatigue is somehow more in the placebo arm, and other anemia, arthralgia, UTI, back pain, and enzyme elevation. Pain is definitely comparable in the both subgroup. Next, please. So here also we can see the rate of adverse event commonly associated with androgen receptor blockers were similar across treatment arm. And here we can see that the both group like darolutamide with androgen deprivation, placebo with androgen deprivation have almost similar side effect profile with good response in the treatment arm. Next, please. So darolutamide confer a positive impact on hormone receptor quality of life. So darolutamide extended median time to deterioration of FACT-P total score by 5.1. Darolutamide is the first and only AR inhibitor demonstrate meaningful delay in the pain progression and overall well-being. So quality of life is better with the darolutamide. The time to deterioration is definitely are not pre-specified experiment is showing that after the 36 months of treatment, darolutamide. Next, please. Why I couldn't see the slide? Oh, there is some issue at my side. Yes, sorry. So the darolutamide doublet therapy demonstrated clinically meaningful delay in the deterioration of overall well-being, especially on social, functional, and urinary symptom domain. Next, please. So in conclusion, darolutamide with androgen deprivation significantly improved PFS in patients with metastatic hormone-sensitive prostate cancer. Darolutamide show a benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of baseline PSA. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delay in the pain progression, overall well-being, including social, family well-being, functional well-being, urinary symptom. Darolutamide had a favorable safety profile. Darolutamide with androgen deprivation without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Next, please. So thanks from my side for me today evening. Any question you can ask?
Yeah, the house is open for the question. If there is no question, so we can close the session, sir. Thank you for
Okay.
giving us the valuable insight on darolutamide, sir. Thanks a lot, sir.
Thanks everyone. Good night.
Yeah, technical team, you can close the session.